I'm ready with my
Well,
presentation.
yeah,
Thank you so
that's good.
much.
That's appreciated.
Should I go ahead?
Well, yes, sure.
Yes. Okay. Let me share my screen and yes. Yes. Is my
Yeah.
presentation visible?
Yes, yes.
Yes.
And
Okay.
you're audible as well.
Okay.
Kindly go ahead.
Yes. Thank you, Dr. Archana. Good morning to one and all. And I am going to just give a brief introduction about myself. I am an assistant professor. I'm Dr. Neetu, working with Apollo Hospitals in Hyderabad, India. And I would like to present or bring forward this topic today in front of you all people, only because this topic being presented as a case report is just to emphasize the fact that a small benign lesion can be masked by a predominant component, which is shadowing the smaller component, and which is not very rare in our daily practice, but it can also make a difference to the main diagnostic, treatment, and prognostic implications in the patient. So I have chosen this topic as a case report. So a few words on the abstract. The tubular adenomas of breast. The title of my presentation is a tubular adenoma of breast, which was missed on cytology, but we got it on our histopathology gold standard and its study of literature. Yes, moving back to the abstract. The tubular adenomas are pure benign epithelial tumors of the breast, as we all know, along with fibroadenomas. So here we report a case of a 18-year-old female who has reported to the Department of Surgery with 1 month history of bilateral breast lumps. When this patient was referred to our Department of Pathology for fine needle aspiration procedure, the smears had shown a picture of bilateral fibroadenoma. The ultrasound findings also were consistent with fibroadenoma picture. Whereas the excision of this bilateral breast lumps had histologic findings which were concordant with tubular adenoma with a bilateral fibroadenoma. So starting with the introduction of the case report, an 18-year-old female was reported to the Department of Surgery with 1 month history of bilateral breast lumps. When this patient was referred to our Department of Pathology, the physical examination of the right breast lump was a well-defined, mobile, a non-tender lump with no skin and with no skin changes and nipple discharge, located in the upper outer quadrant, measuring 6 by 4 centimeter. Whereas the contralateral breast, that is, the left breast, had a lump which showed features similar like in the right breast, that is, a well-defined, mobile, non-tender lump was also seen in this breast, but located in the upper inner quadrant, measuring 2 by 1 centimeter. A fine needle aspiration had yielded a diagnosis of bilateral fibroadenoma, which was later followed by surgical excision of these breast lumps. So to our surprise, we were taken aback when we had seen some of the lesion hidden there. That is, the histopathology report had concluded a tubular adenoma of the breast with intracanalicular fibroadenoma in the right breast and a fibroadenoma in the left breast. Her post-operative course was uneventful. So here comes the sonographic appearance as the slide that is put in display in front of all of you. This sonographic appearance of the fibroadenoma, which is showing ovoid smooth muscle mass with a narrow antero-posterior diameter than its transverse diameter. As pathologists, we should also be knowing how to give importance to the clues that are given on the radiographic examination, because along with the clinical details, the radiographic examination findings can also bring our way closer to the diagnosis of what we can give on histopathology. So moving on to the cytologic details. The cytology, the fine needle aspirate smears were moderately cellular, composed of cohesive clumps of bland appearing ductal epithelial cells with bare nuclei and occasional stromal fragments in the background, which was given as fibroadenoma of bilateral breast lumps. So the figure shown is in this, as you can see, the figure 2, which is showing the high par view of the FNAC smear fine needle aspirate, showing a tubule composed of epithelial balls in the naked nuclei background. But this tubule configuration was only seen as a retrospective when we looked back into the slides, but we had initially given this as fibroadenoma. So on macroscopy, that is on gross, we received 2 soft tissue masses, and the largest soft tissue mass was solid, homogeneous, whitish appearing mass with smooth surface appearing, measuring approximately 6.5 by 4 by 2 centimeter, that is seen in this figure. This is the gross image of the larger lump what we had got. And now moving back to the smaller soft tissue mass, the soft tissue mass, the other soft tissue mass was showing similar features like in the large mass and measuring 2 by 1 centimeter. And when we had seen the microscopy of these nodules, we had seen that the larger nodular mass did show features of tubular adenoma in the larger nodule and features of intracanaliculair fibroadenoma in the adjacent breast tissue of the same nodule. And whereas the smaller nodular mass revealed a fibroadenoma picture. So as I have discussed, this is the gross photograph of the larger lump, which was quite big, smooth surface, and gray-white also to be seen, and solid and fleshy. And in this figure, we can see a fine needle aspirate cytological smear with the few bare nuclei in the background. There were no stromal fragments in this, but there were this tubular configuration arrangement of the epithelial cells. And the subsequent figure, that is figure number 3, shows a low power view of hematoxylin and eosin stained image, which shows a intracanalicular fibroadenoma and a tubular adenoma. Like we can see in this picture, I have magnified it. The intracanalicular component of the fibroadenoma is enclosing the tubular adenoma component. And this is the higher par of the hematoxylin eosin stained image, which shows a uniformly packed tubules, which are lined by a single layer of epithelial cells with attenuation of the myoepithelial cells. So moving on to the discussion part of this entity, clinically painless, they are well circumscribed lesions which are freely mobile are usually considered as fibroadenomas. That is lumpy, bumpy breasts. So this is usually fibroadenomas, like what we all know. So breast adenomas has a classification. They are divided into true adenomas, nipple adenomas, and fibroadenomas according to Hertel et al. The true adenomas are again divided into tubular, lactating, apocrine, ductal, and pleomorphic adenomas. So the tubular adenoma and fibroadenoma of the breast together comprises only 4% of the benign breast lesions and 11% of the breast adenomas. According to Majorano and Albrizio's study, tubular adenoma and fibroadenoma are histologically related with a predominant stromal tissue in the fibroadenoma, whereas ductular proliferation seen in tubular adenoma. According to Oral, cytologic smears include uniform tubules arranged in three-dimensional epithelial balls in a background of naked nuclei, but no stromal fragments. So whatever the salient features, the positive features are looked upon, it is equally important to look at the negative findings as well to rule out differentials. A giant tubular adenoma of the breast was reported in a patient with Maffucci's syndrome in one of the articles. So what is Maffucci syndrome? I would like to just talk a few words on Maffucci syndrome. Maffucci syndrome, let me remind you, Maffucci syndrome is seen associated with giant tubular adenomas of breast. They are congenital, non-hereditary, mesodermal dysplasias with multiple enchondromas and vascular lesions. So, here are a few additional pointers as to how we can name any lesion as a tubular adenoma and when to call it as a fibroadenoma. Tubular adenoma, a few historic points. Tubular adenoma was first described in 1968. Different workers reported that 90% of patients with tubular adenoma was seen usually in reproductive age group of women. Even pregnant women had shown this tubular adenoma growth. So usually it is seen below 40 years. The size range of tubular adenomas varies anywhere between 1 to 7.5 centimeters. Clinically, these tumors are painless, freely mobile, circumscribed lesions which resemble fibroadenoma, thus making preoperative diagnosis very difficult because in the most of these cases, the clinical findings and imaging features resemble a fibroadenoma. Few researchers proposed that the pattern of dense punctuate or irregular microcalcifications without cast-like or branching forms that are tightly grouped within mass. Few of the pointers indicate this as tubular adenoma finding on fibroadenoma. Majority of these lesions in young patients, they simulate a fibroadenoma without any diagnostic calcification. Therefore, tubular adenoma cannot be differentiated from other benign breast diseases on radiologic examination. Tavasoli et al. Called a nodule as tubular adenoma only if 1 centimeter in size or if it was smaller and encapsulated. Domato et al. Reported a case of synchronous recurrence of tubular adenoma with a component of ductal invasive breast cancer. So it is very important to even find the lesion masked by the predominant component because it can have a focus of the invasive component, which can be dangerous for the patient perspective. Moving on to the microscopic images. Here we see, these are the images of the tubular adenoma, which have tubular shaped glands, usually they are uniform, with a sparse intervening stroma. On immunohistochemistry, IHC, the P63 focal positivity, P63 and calponin are usually the markers for myoepithelial cells. So the P63 and the calponin, that is the images seen in C and D labeled here, they are stained positive. This indicates a tubular adenoma, that is attenuated myoepithelial cells stained P63 and calponin positive, and the epithelial component is also there. So, tubular adenoma has few differentials which can cross our minds at the time of diagnosis. First entity is sclerosing adenosis. Now, what is sclerosing adenosis? It has proliferating tubules which are usually lined by two cell types that are elongated and also may acquire spindle-shaped myoid features. On immunohistochemistry, IHC, these come out to be P63, smooth muscle actin, and calponin positive. Presence of the basement membrane around these tubules, type 4 collagen is usually seen deposited as a basement membrane. These can be stained with per acidic per, that is PA stains, per acidic Schiff positive stains can come out positive on this to show us the type 4 collagen. The next entity that can come as a worrisome differential, that can be microglandular adenosis. Microglandular adenosis also shows small uniform glands with open lumina containing some eosinophilic secretions like what is there inside this photograph. So these have a irregular fashion of distribution within the fibrous tissue. The myoepithelial layer is usually absent for microglandular adenosis, ruling out the tubular adenoma. Only benign, the microglandular adenosis is the only benign epithelial breast lesion which is devoid of myoepithelial cells. Now moving on to the immunohistochemistry panel of microglandular adenosis. Here we see that there is a pancytokeratin positive around the tubules, that is the epithelial cell component being positive. And the second image in this slide showing the smooth muscle actin negativity around the tubules. So that shows that there indicates that myoepithelial cells being absent. So this differential gets ruled out. So I would like to conclude that the clinical features and imaging studies of tubular adenoma, they resemble fibroadenoma, thus making preoperative diagnosis for the clinician, that is the surgeon, and for the pathologist to make this lesion tough. To avoid it, surgical excision plays an important role in making the right diagnosis of this benign epithelial lesion. Through this case report, it is clearly implied that diagnosis made on fine needle aspiration is only a tentative one, and it has to be supported and validated by a gold standard histopathological examination. So these are my references, as we can see in the last slide. And thank you so much. I'm open to any questions concerning my topic.
Well, thank you, Dr. Neetu, for an outstanding presentation from your side. As we all know that it is quite common in our usual practice to miss certain cases on cytology, especially when there is a lot of cytomorphology overlap, but they can be reliably caught on histopathology examination and then uh, tallying them with the
With gold standard.
IHC markers. And today, Dr. Neetu had contributed through her presentation about one of such a case, that is tubular adenoma. And she had spoken really well about the tubular adenoma in detail. And she has also discussed wonderfully through her beautiful HND pictures and distinct IHC slides where we were able to appreciate the IHC staining as well. And she has also enlightened us about the differentials for the tubular adenoma. That was really nice. And finally, thank you, Dr. Neetu, for making your presentation really interesting. It was pleasure to have you on this platform for all of us and sharing your knowledge on this platform.